Alright guys, welcome back to the continuation of NBME 22. We're now up to question 80, almost there to block 3. I do 20 questions per video because it gets pretty extensive, so just the breakup of the blocks are a little different than what's conventional, I guess. Let's see, just give me a couple minutes. Alright, so last time we left off right here. As I told you guys, I've been compiling a list of topics that are on this NBME. Alright, so we've got quite a nice list of things that are on this NBME. NBME 22 is actually pretty nice. I feel like it's very relevant to how your actual step 1 will kind of look like. There was one biochem question about the hexosaminase pathway, which is really random shit, so don't worry about that at all. You can look it up if you want to. It was a very basic question about, well, I can show it to you guys right now. Number 75. Yeah, this one right here. Right, which of the following is required for glucosamine synthesis for fructose 6-phosphate? So this was just a bullshit question. You can see fructose 6-phosphate becomes glucosamine 6-phosphate thanks to glutamine. Right, so that was the answer there. That's part of the hexosamine pathway. Not a very realistic thing. I'd be very shocked if it was actually on your step 1. But that happened. But the main point is that it's very rare to have any biochem questions on NBME. The point of such a list was to kind of show you guys what are common topics on NBME, as well as what is a recurring topic within the same NBME and across multiple NBMEs, right? Because people who are studying specifically for an NBME, because either they need to take it for school or whatever, they should focus on these topics specifically, right? So I'm going to go ahead and keep continuing on putting this list together as we keep going through questions. All right, here we are, question 81. This is an acid-base physiology question, so I already added that to the list. A newborn has cyanosis, tachypnea, and retractions of the muscles of the chest wall during inspiration. She weighs 5 pounds and 8 ounces. Arterial blood gas values while she breathes room air are pH 7.04, so that's very acidotic. PCO2 is 65, PO2 of 35, and bicarb 15. Okay, so which of the following best describes her acid-base balance? And then they're giving you metabolic acidosis and alkalosis, and then respiratory acidosis and alkalosis, and then E and F are mixed. Right, so this is a very interesting question. You have to be very good with acid-base physiology questions, but the way this one is asked is quite confusing. First, you have to understand what the pathology is. Anytime you're tackling acid-base physiology questions, you have to tackle the actual, you have to know what the actual problem is. What's the actual pathology in the patient? So let's actually go with acid-base physiology real quick. Right here. So you can see right here, when you look at this graph, this chart or whatever, has many different pathologies over here, right? And you have to be good at understanding how you got to, why is methanol over here, why is anxiety over here, how those things occurred, so that they got placed into the place or box that they're in. And you definitely need to remember the normal values of things, right? So you can see how PCO2 is 36 to 44. Bicarb is 20 to 28, right? So let's move that over to here too. I see now. Make this a little bigger. Okay, so now looking at this, you can see, right, pH is obviously very evidently low. PCO2 65 is high, right? PO2 35. Remember, oxygen should not be so low, so it is a little low, and bicarb is 15, which is obviously also very low. So at this point, right, looking at this, the fact that all the numbers are off, right, not just 2, but all the numbers are a little off, seems like compensation most likely has occurred, okay? So it's very likely that whatever the patient is going through might have been something chronic, but it seems like compensation has already occurred, or there's a mixture of two things. Okay, so at that point we can definitely knock out most answer choices that would have uncompensated, and that's pretty much all of them, right? The first four, right? You can knock out all four just by knowing that it's not sheerly metabolic acidosis, it's not sheerly just metabolic alkalosis, it also isn't just respiratory acidosis or respiratory alkalosis, right? Because they're saying uncompensated. So if compensation had not occurred, right? Think about it. For metabolic things, right? Metabolic things, compensation is very quick because you can control your breathing almost immediately, right? You can breathe very slow if you want to, or you can breathe very quickly if you want to, at your own whim, right? Within seconds. So metabolic things, any A or B, would be compensated by breathing very, very rapidly, and you would have a shift in PCO2, right? Here, PCO2 is very high. So that would be something like hypoventilation, and you would be hypoventilating because you're trying to retain CO2, which would mean that you might have metabolic alkalosis, right? But if you had metabolic alkalosis, bicarb would be high. Right? You get that? So it immediately is not B. If you had metabolic acidosis, then your bicarb would be very low, and to fix that, you would be hyperventilating. Right? So this patient, it's a newborn, they didn't give a gender. Oh, she, yeah. So her bicarb is low, so let's assume maybe it's metabolic acidosis. If she was going to compensate for it, right, she was going to go ahead and breathe really, really quickly to unload PCO2, right? And if she did not compensate, as they're saying here, uncompensated, answer choice A, if it was uncompensated, then PCO2 would just be within normal levels. However, all three, not talking about PO2, everything besides PO2, the pH, PCO2, and your bicarb, all three of those values are altered. Since all three are altered, some compensation has definitely occurred, or you have a mixture, okay? So since we can knock out A, B, C, and D based off of that immediately, it must be some level of mixture, okay? So it's either going to be E or F. We literally come down to that. Just because we have some mastery of acid-base physiology, and I hope that makes sense to you guys, that you can knock out A through D immediately just because you know some compensation must have occurred, or it's a mixed issue. Oh, let me make sure this is HD. All right. So because we know it's not clearly, the answer must be between E or F, so it's definitely not a compensatory thing, then we now have to pick whether it's respiratory acidosis and metabolic acidosis, or respiratory acidosis and metabolic alkalosis. Well, it's very obvious this is not going to be metabolic alkalosis, because if you had metabolic alkalosis, bicarb would be high, right? This is low bicarb, which is metabolic acidosis, and very high PCO2, which is respiratory acidosis, so the answer would just be E. Okay, this is theoretically a pretty easy question, but if you're intimidated by acid-base physiology, and definitely if you're intimidated by mixed issues, then you're definitely going to be very lost. Now, how do you actually evaluate this, right? Because they do teach you this in first aid. They give you these equations here. There's the Henderson-Hasselbalch equation for finding pH, which you almost never use. And then there's the Winter's formula for finding concomitant issues, right? Concomitant respiratory acidosis or concomitant respiratory alkalosis. This is where you use the Winter's formula. So how would we apply the Winter's formula? So first you analyze the data. pH is low, bicarb is low, CO2 is low. There's two different types of acidosis occurring. If you see it immediately, you just pick E and move on. But let's say you have a lot of time. So what I've learned is that in essence, metabolic acidosis always takes priority in these scenarios. Definitely want to make sure you remember that. It's evident that the person is not compensating, but you want to calculate anyway by using Winter's formula, which is 1.5 times the bicarb plus 8. And then there's a plus or minus 2 part, but you don't really need to worry about that too much. Just have that in the back of your head. So 1.5 times bicarb plus 8. So 1.5 times bicarb plus 8, that would give you about 30.5, right? If you calculate, you will see that the expected is 30.5, right? So you do the calculation, you get 30.5. Now, if CO2 is higher than the expected, that means you have respiratory acidosis on top of metabolic issues. And if CO2 is lower than expected, then you have respiratory alkalosis. Here, it is higher than the expected, right, which is 65, okay? 65 you get from doing 1.5. Let me see. The bicarb they gave you is 15. Yeah, so 1.5 times 15. Wait, where did I get the 65 from? Wait. Let me do the calculation real quick. So 1.5 times the bicarb they gave you is 15 plus 8. Yeah, that's the 30.5. Where's the expected? Oh, 65 is your PCO2. Right. You're right. My bad. Excuse me. Your winter formula gives you this number, 30.5, and you're supposed to compare that to the PCO2. I was thinking bicarb, excuse me. So this 30.5, right, is compared to the 65 that's here, and you just work with that, and you know immediately from there that it's E, respiratory acidosis and metabolic acidosis. All right, but in my honest opinion, you're not really going to have time to use the equation. You're really not going to want to memorize another equation either. On top of that, it's pretty low. It's not a high yield topic to have mixed metabolic and respiratory derangements, especially on, like, I don't even think I've ever seen that kind of topic on UWorld. So what you would do, right, is that you would just analyze it the way I did, right? First things first, you realize all three of these things are altered. If all three things are altered, right, that only occurs if compensation has occurred or there's both metabolic and respiratory derangements. Since all four of these first answers are uncompensated, none of them can be correct. So then the only answer choices that were left were mixtures, and you have to pick acidosis all around because that's all you're seeing here, right? pH is low, PCO2 is high, bicarb is low. Those are all three different forms of acidosis. That's it, right? So not so bad at all. And that's how you kind of apply the Winters formula, right? PCO2. PCO2 equals that, and you compare it. Excuse me. All right, so now this is another pretty high topic. This is the second time they're asking a question about G protein messengers. Question number 67 in this test was also G protein messengers. So you do want to make sure you memorize that really well from first aid. So here they're just asking, a 42-year-old woman with frequent heartburn has relief of symptoms with ranitidine treatment. And ranitidine, remember dinner for two, is an H2 blocker, right, for gastric acidity. The therapeutic effect of ranitidine is most likely mediated by a receptor whose activation increases which of the following in the parietal cells of the stomach. Right, so now H2 works with GS to increase cyclic AMP. How are you going to memorize that, right? The answer here was just B, cyclic AMP. How would you memorize that? So let's go take a look at this in the book. So when we come here, right, this is the page with all your receptors. Obviously, you need to know all the receptors and what they do because that's a big part of pharmacology. And then the rest of it is knowing this part, right? So can I have one M&M? Really just helps you remember that because this is a question, this is GQ, right? And the C reminds you of phospholipase C and protein kinase C, all of that stuff. HAV, they're all 1. H1, alpha 1, V1, and then the first M and the third M for M1 and M3. Very straightforward. MAD2 or 2-MAD, you're so mad that you inhibit everybody else, right? So MAD2 are the GIs, everything else is GS. So H2 falls into GS, which stimulates cyclic AMP, right? That's it. Can I have one M&M? That is a GQ, which works with DAG and IP3. You have to remember GQ works with DAG and IP3. The rest of it all just fits into the mnemonics. Can I have one M&M? And 2-MAD, so you inhibit, either you inhibit themselves or you inhibit everybody else, right? Oftentimes mad people stop others from having fun, so that's what I'm talking about when I say you inhibit everybody else, because GI inhibits all the other things. So, that's basically all you would really do to memorize this stuff. There's really no other way to memorize this topic. Okay. Here, this is a physician is unable to communicate bad news to a patient because the patient reminds him of his older brother who always intimidated him. Which of the following terms best describes this reaction? This is just a straightforward topic of transference and countertransference from psychiatry. Here the answer was B, is countertransference. They were very nice to you in this question. They didn't put both things. They didn't put transference and countertransference. So remember that the patient is saying things, right? Patients say things, that's transference, while doctors reply to what the patient says. So that's countertransference. Just to remember which one is which, right? So what's happening in this question, The the physician is doing it to the patient, so that's countertransference. Okay, transference is when the patient says that the doctor reminds them of their father or mother or something like that. So not so bad at all. Just to take a quick look at that page. Remember, always revisit first aid when you're doing questions, New World or wherever, because it really helps you create a mind map of all the topics that are on that page. Right. So we're looking at transference versus countertransference. These are basic images to show you how that works. Okay, so remember that the patient says things when they walk into the clinic. That is transference. And the doctor replies. Replying is like a counter, so countertransference. So far, not so bad. Again, the questions on NBME 22 were, I would say they weren't ridiculously hard, but they were pretty nice questions because they were very step one like questions. Of all the NBMEs I've done so far, 18, 20, a couple that I've done the videos for, I liked 22 the most so far because I feel like the questions are very good for teaching purposes and for really gauging how prepared you are for step one. So here, a 54-year-old man who works in a delicatessen comes to the physician because of decreased sensation of the tip of his right index finger. 6 months ago, he severed his finger while slicing meat, and it was successfully reattached by prompt surgical repair. Examination of the finger shows muscle wasting. Which of the following cells is most likely blocking reinnervation of the muscles of this patient's finger, right? So what's blocking reinnervation? So basically, obviously, when that finger must have been severed, there was nerve damage, and this is a question about Wallerian degeneration and chromatolysis. Of the options available, right, astrocytes, microglial cells, oligodendrocytes, satellite cells, and Schwann cells, of the options available, Schwann cells would be the only cells that are actually present in the PNS. Astrocytes, microglia, satellite cells, and oligodendrocytes are mainly CNS cells. Satellite cells are also glial cells that are formed around damaged nerve cells, but they're known mainly for the CNS stuff. Reinnervation is assisted by Schwann cells, but the process is very delicate. After Wallerian degeneration, the Schwann cells must basically line up perfectly along where the nerve is supposed to grow. But it doesn't happen so perfectly, and the Schwann cells get disorganized and often prevent proper reinnervation. Right, so if we take a look at that topic real quick. Wallerian. So it's 483 for first aid, but 537 for my book. So if you look at that image that they give, right, there's a couple things you need to know. There's chromatolysis, and then Wallerian degeneration is right under it. This is always supposed to be together, but it wasn't in previous first aids. So you see how the Schwann cells here are all messed up, right? Now, of course, a lot of people wanted to pick microglia, right? And you do have microglial cells here as an answer choice, but that's more of a CNS thing, not exactly a PNS thing. In the peripheral nervous system, right, these Schwann cells will come and try to reconnect in the same exact manner, right? And that doesn't work out because there aren't really other cells there to kind of help guide them, go into the perfect line and just connect the way they originally were. So it's kind of like a shattered mirror. You can't really reconnect it the same exact way. You're always going to have some lines here and there. So, disintegration of the axon and myelin sheet distal to the site of axonal injury with macrophages removing the debris. Serves as a preparation for axonal regeneration and functional recovery. However, it doesn't really work out that well. Okay, UWorld has a couple questions about it. Right? So the persistent myelin debris and axonal reaction. Axonal reaction is basically the chromatolysis stuff, right? Reaction of neuronal cell body to axonal injury. Changes reflect increased protein synthesis in an effort to repair the damaged axon, and it looks like this, right? Round cellular swelling, displacement of the nucleus, and dispersion of mesal substance. And so these topics go together, very nicely explained by first aid. A couple good questions here and there on UWorld as well as AMBOSS. So whenever you see it, it shouldn't be the most confusing thing on earth. Here in this explanation, in the PNS, Schwann cells recruit macrophages and effectively clear myelin debris and regenerate. Microglia are recruited slowly due to the blood-brain barrier, so debris remains for years when it's in the CNS, right? Brain issues. But in the PNS, just macrophages come and clean things out. However, Schwann cells are the guys that end up, not aligning perfectly in the PNS and then block successful repair, reinnervation. so this one, let me edit this real quick. Okay, perfect. Okay, so this question says, a previously healthy 28-year-old man comes to the physician's office because of severe abdominal pain accompanied by nausea, vomiting, and blood in the urine. Temperature is 98.1, so it's pretty much normal. Pulse is 100, respiration is at 20, blood pressure is high. The patient appears to be in distress and occasionally writes in pain. Abdominal examination shows a flat abdomen with hypoactive bowel sounds. There is mild tenderness on palpation of the right middle and right lower quadrant of the abdomen and the right flank. There is no rebound or guarding. The testes are normal and no hernia is palpable. Which of the following is the most likely diagnosis? Now, the way that this patient is presenting is exactly what happens when you have a stone that's going through your ureters, right? So renal stone, kidney stone going into the ureter is painful. There's a couple things they tell you in this question to help you knock out other answer choices. For example, the no rebound or no guarding, that helps you knock out a couple things. There's no hernia, the testes are normal, so you can knock out many things. Now, if you look at the answer choices, acute cortical necrosis, papillary necrosis, or tubular necrosis, these things are not necessarily painful in the way he is, right? The patient is in distress and writhes in pain. That's not how these things present. Neither does cystitis present that way, or glomerulonephritis, hypernephroma, I'm not entirely sure what that is. Neither does interstitial nephritis or pyelonephritis. None of these things actually present in the way this patient is presenting. Okay, he's in a lot of pain because a stone is going through his ureter and it's hurting a ton until it finally comes out, until he finally urinates it out. Right? That's just nephrolithiasis, and you're pretty much done with that. Right? Nephrolithiasis is the correct answer. 85% of nephrolithiasis is associated with hypoactive bowel sounds. The pain from nephrolithiasis can relapse and remit, and occasionally the pain can travel from the kidney to the scrotum as the stone moves through the ureter. Right? Flank pain. And that's all this patient was doing. There's many, like if you watch Friends, there was an episode once where Joey had a kidney stone. Right, that was exactly how this patient is presenting too. Everything's just fine, right? Even the blood pressure part, the only reason his blood pressure is slightly elevated is because he's in pain. That's it. It's not something that seems like a chronic issue for him. And he's pretty young. He's 28, so nothing crazy. The nausea, vomiting, and blood in the urine is all happening because of a stone. Thyroid. Okay, so this is pretty high yield too. NBME always finds really interesting ways of asking questions about T3, T4, and all that stuff, TSH. We already did one question about this in the same NBME. This is the second one here. 29-year-old woman comes to the physician because of a 5-week history of fatigue and a 4-day history of heart palpitations and anxiety. She has primary hypothyroidism treated with T3, triiodothyronine. She says that she has doubled the dose of the medication over the past week because of fatigue. Her pulse is 112, blood pressure is pretty normal. Physical exam shows a fine motor tremor of the hands. Deep tender reflexes are brisk. Thyroid function testing is most likely to show which of the following sets of serum concentrations. Now, before we look at anything, I want to stop you guys and want you to realize, when you get a patient being treated with hypothyroidism, you really think of them treating it with levothyroxine, right? I've almost never heard of someone treating their hypothyroidism with triiodothyronine, right? So when you read that, that should have been a big message for you. Something is funky here, right? Levothyroxine is actually T4, which goes into your body, and then your body can use as much of it as they need to by making it into active T3. Triiodothyronine is actually T3. So why is this patient presenting with fatigue and heart palpitations and anxiety and whatnot? Okay, so I went on to explain a particular thing was that she takes triiodothyronine, not levothyroxine, which I just told you. So she doubled her T3 intake. She doubled her T3 intake, which is why B and E are wrong, right? Because what happens in B? In B, they're saying that her free triiodothyronine is low, right? And E also free triiodothyronine is low. It should not be low. Her free T3 should be very high because she's eating a shit ton of it, okay? So you can immediately knock out those two answer choices. this high T3 is active, so her TSH will decrease as a negative feedback, right? So now you cut out A, B, and C, so A and C also go out. So you're really just left between D or F, okay? Now, what's going to happen to free thyroxine, right, which is levothyroxine, T4? This will then also lead to lower thyroxine, because without TSH, you don't make more thyroxine. So the answer here would just be F. Okay, very interesting, weird, delicate way to ask this question. Kind of silly, but it is what it is. So the answer was just F here. Okay, and that's how you deduce it. Think very coherently, very organized, very logically. Here, an 81-year-old man comes to the physician because of ongoing management of hypertension of 20 years duration. Okay, so he's super old and he's had hypertension for 20 years. His temperature is 98.2. Pulse is 80 per minute. Respirations are 20 per minute. Blood pressure is 200 over 110. To reconfirm the patient's blood pressure, the physician places his index finger over the radial artery while inflating the sphygmomanometer, which is, just a blood pressure cuff, just above the previously measured systolic blood pressure level. At this point, the radial artery becomes non-pulsatile, but remains easily palpable even as the cuff is further inflated. Which of the following best explains this phenomenon? Okay, so first of all, which of these is most likely to occur in an 81-year-old patient with hypertension of 20 years? That's how you want to tackle things like this, right? Which of these is most likely to occur? Left ventricular hypertrophy can occur, not really thrombosis, not really vasculitis, not necessarily connective tissue disease. Atherosclerosis occurs to almost everyone after 50. So the most likely answer choices here would be A or C. And since we're talking about a blood vessel, not the heart, you would just pick A and just move on. Right? That's actually how you would really come to know what's happening. Now, what is the actual theory in this question? They're talking about an artery where once you could feel blood going through it, you could palpate the artery, okay? Now you squeeze the artery to a certain extent with a blood pressure cuff, and all of a sudden no blood is passing through it. The only explanation for that is that there must be some kind of plaque. And so let's take a look at what I'm trying to talk about. So you have a big blood vessel, right? That's the lumen of the blood vessel, okay? And maybe you have atherosclerosis that's covering about 50% of the flow. So only blood can flow up here, okay? Now if you have a blood pressure cuff, right, and you squeeze this portion really hard with the blood pressure cuff, now blood can no longer pass, right? Because now you basically narrowed the lumen. You narrowed the lumen down to this much with your blood pressure cuff, right? Because you're squeezing the vessel. So now blood is going to be stuck. It won't be passing because there's an atherosclerotic plaque right there. Okay, and that's what happened in this patient's physical exam. Basically, that's what they're basically talking about. So if you ever get a question where they describe some stuff like this in that manner again, that's all you really want to look for. Okay, so don't get too confused. I mean, it's pretty deducible information. You can definitely figure it out. And then, of course, always think about things in a very logical manner, right? Of all of these things, what is the most likely thing that could happen to an 81-year-old patient anyway, right? 81-year-old patient with hypertension. Hypertension is pretty damaging to blood vessels, right? And damage to blood vessels is pretty much the initial impact of starting atherosclerosis. Hypertension also causes left ventricular hypertrophy, right? Because you have to push against a higher afterload. But this question wasn't about the heart. Okay, so now they give you a peripheral smear. So, previously healthy 45-year-old woman has had fever, confusion, and decreased urine output for the past 2 days. Temperature is 101, which is high. Labs show a shit ton of stuff. So, hemoglobin is low. White blood cell looks okay. She has reticulocytes, so she's trying to make red blood cells, but it's not good enough, I guess. Mean corpuscular volume is okay. Platelet count, 18,000. That's not okay. Prothrombin, 12.8. PTT, 32. Fibrinogen is normal. Fibrin split products, less than 10. Right, so this stuff, the fibrin split products and fibrinogen, this is actually very significant for DIC. And these numbers are normal, so it's not DIC. Right, so you cannot get answer choice B. And then it's not aplastic anemia, because aplastic anemia would really not have anything. It's not liver failure, right? Because liver is responsible for making your coagulation factors, and her coagulation stuff looks okay. Vitamin B12 deficiency would have neurologic symptoms, right? Which she doesn't really, she has some confusion. But other than that, they didn't give you anything else. And you would see hypersegmented neutrophils in both B12 and a folate deficiency, but we don't really see that on the peripheral smear. So now we really have to focus on the peripheral smear, and we look at it. You're mainly seeing only red blood cells here, and they all look kind of weird, right? There's some pointy red blood cells like this one here, that one there. There's some that have a lot of central pallor, whereas this one that doesn't have any central pallor. So something really weird is happening. Now, the only asteroids that was left that we didn't really knock out is TTP. And you need to remember, what happens in TTP and HUS, hemolytic uremic syndrome. If ITP was an answer choice here, you would have to consider that one too. But ITP is not an answer choice here. TTP is. TTP is fun art, right? Fun art. Fever and neurologic symptoms, as well as anemia, renal, and thrombocytopenia problems, right? And she does have thrombocytopenia, platelet count 18,000. So TTP perfectly fits her scenario. They gave you the fever and confusion, which is their fever and neurologic stuff. They gave you the anemia, right? They haven't really necessarily told you that she has renal problems, but she most likely does. And thrombocytopenia is given. Okay, HUS is just art: anemia, renal, and thrombocytopenia. HUS is hemolytic uremic syndrome, which usually occurs in kids after an E. coli issue. So let's take a look at this real quick. 459. Alright, so disorders overlap significantly in symptomatology, right? TTP and HUS, but TTP is an inhibition of ADAMTS13, which is a metalloprotease that degrades von Willebrand factor multimers. So now you end up having large von Willebrand factor multimers, and that causes more platelet adhesion and aggregation, leading to microthrombi formation. Remember that microthrombi always occlude, blood vessels, and as blood passes through the microthrombi shreds the blood vessel, giving you schistocytes, right? So you end up seeing schistocytes. You end up having hemolytic anemia because that microthrombi is going to break your red blood cells as they're passing through. But you see normal PT and PTT, right? Normal PT and PTT helps distinguish ACOS and TTP from DIC. And they gave us a lot of stuff in our question to not pick DIC, because fibrin split products, which are your D-dimers are normal in this patient, okay? And really wasn't any reason to pick any other answer choice. So that was really it for this question. Pretty nice question. The fun art versus, HUS is art. That's just something that I use to remember the fever and neurologic, anemia, renal, and thrombocytopenia. TTP is a very interesting question type. As is ITP. These two hemonc topics are actually very high yield. ITP more common than TTP in terms of question volume, because ITP can just occur for no reason whatsoever, right? It could be idiopathic. So you could have a perfectly normal patient with everything okay, doesn't smoke, doesn't do anything bad, blah, blah. Everything's perfectly fine, but for some reason they're going to be presenting with symptoms of thrombocytopenia. That's just ITP. That's it, right? Of course, it can also be due to secondary to many other things, and look at the number of things it could be secondary to. So, ITP is a very common answer choice. TTP is another common answer choice, and things that you don't see in ITP that you do see in TTP are the fever, the neurologic symptoms, stuff like that. And it's because of the neurologic symptoms that they actually put vitamin B12 here, right? But vitamin B12, you have to remember the more important thing here, this is megaloblastic, right? And you're going to have hypersegmented neutrophils, and we weren't given any of that. So that was no real reason for you to pick B12 deficiency either. B12 deficiency doesn't have fever. Okay, this is actually pretty cool too. This is a good question. Sirolimus and tacrolimus, as well as cyclosporin and other medications on that page, are very high yield immunosuppressants. So a 39-year-old woman with rheumatoid arthritis comes to the physician for a follow-up exam. Treatment with multiple medications, including prednisone and methotrexate, has not been effective at slowing the progression of her condition. The most appropriate next step in pharmacotherapy is a drug that blocks the effects of which of the following cytokines? Okay, so rheumatoid arthritis. You look at all your answer choices: interferon gamma, interleukin 2, 4, 10, and TNF-alpha. Immunosuppressants for rheumatoid arthritis are calcineurin inhibitors like cyclosporin and tacrolimus, 6-mercaptopurine, and TNF-alpha inhibitors like adalimumab, infliximab, etanercept, etc. It is important to distinguish that calcineurin inhibitors block T-cell activation by preventing interleukin-2 transcription, not necessarily block interleukin-2 action. Sirolimus, which is rapamycin, blocks interleukin-2 action, but it is used for kidney transplant rejection prophylaxis specifically. TNF-alpha inhibitors are for IBD, rheumatoid arthritis, psoriasis, ankylosing spondylitis, and a couple other things that aren't even in the book. The only med to block interleukin-2 receptors is basiliximab, which is also used for kidney transplant prophylaxis. So let's take a look at these medications. You do need to memorize them. There's a couple things there. There's also a nephrotoxicity between the couple medications that you can mix together. So cyclosporin, tacrolimus, sirolimus. These first three medications all kind of go together, because you have to remember that sirolimus is synergistic with cyclosporin. You have to remember that. Both of these guys are nephrotoxic. They tell you here, right? Both calcineurin inhibitors are highly nephrotoxic. So that's one reason to not really combine cyclosporin and tacrolimus. On top of that, cyclosporin, right? They tell you, it causes gingival hyperplasia and hirsutism. Tacrolimus also can cause hirsutism. Right. Sorry, the main point, my bad. It doesn't cause it. But the main point is what you can combine cyclosporin with. You need to remember what you can combine cyclosporin with. I always remember cyclosporin as a spore thing, right? Spores are hairy, so imagine cyclosporin to be a hairy thing, and remember that it causes gingival hyperplasia and hirsutism. Tacrolimus does not, but the main issue is you need to be able to give something else with cyclosporin. It's not really enough alone, right? Cyclosporin just prevents interleukin-2 transcription. Tacrolimus is another medication that works very similarly, prevents interleukin-2 transcription, using different proteins. This one binds cyclophilin, this one uses FK506. Not the most high-yield topic, but the thing is the diabetes part. Tacrolimus increases risk of diabetes. Sirolimus also causes insulin resistance, which is practically diabetes. Right, so now the problem comes, what medications can you combine? Because you need something that has a different mechanism to make sure that the medications work well together. To have more synergy between the mechanisms. Sirolimus has a nice synergy thing, right? Sirolimus prevents response to interleukin-2. Right? This works differently from both of these medications. So where would you combine sirolimus? Do you combine sirolimus with tacro, or do you combine sirolimus with cyclosporin? And the better medication to combine sirolimus with is the cyclosporin, right? Because if you combine both of these guys, you're almost bound to get the diabetes. Okay, but combining sirolimus with cyclosporin is okay because siro is not nephrotoxic. Okay, sirolimus, you have to remember the pancytopenia, right? Pancytopenia is a big side effect here. The big side effect of cyclosporin was the spore thing, the gingival hyperplasia, and the big side effect for tacrolimus is just the diabetes part. Okay, very similar to cyclosporin. So that's just something that comes up pretty often. You don't really give these two medications together because the real issue is they both work the same way, so there really isn't a major benefit to giving them together. Now, in our patient, right, we're figuring out TNF-alpha. So that's the inadacegoli, those medications at the end, right here, right? Adalimumab, sertolizumab, golimumab, infliximab, a bunch of these guys. Now they only have 2 in the book, but I kept all of them there anyway because there was no reason to take them off. These guys are used for rheumatoid arthritis, so that's what the question was about, right? Autoimmune disease therapy. Ecolizumab is the one for PNH, and natalizumab is for MS and Crohn's. Ustekinumab, I've never really seen in a question, is for psoriasis. Right, so these are really silly ones that you can definitely get on your NBME. You can definitely get on your step 1, and you won't really remember it unless you've memorized it by just revisiting it multiple times, because you're not really going to find many questions on it either. Right, this is pretty high yield, but these 3 over here, I've never really seen many questions on. Maybe 1 on natalizumab, but that's about it. Okay, so you can definitely get a question where they, all of a sudden have a question about PNH, and then they're asking you about this medication, and they really want you to pick this as an answer choice. So if you didn't look at it, you're not going to pick C5 as an answer choice. So definitely make sure you spend a little time here once in a while on this page with, these 3 pages about immunosuppressant medications, because it's pretty significant stuff and very easy too. It's just extra information that's annoying to memorize, but you can definitely do it. Okay, so now 57-year-old woman comes to the office because of a 5-week history of progressive weakness in her arms and legs. She says the weakness is most apparent when she tries to lift dishes out of overhead cupboards and when she walks up and down flights of stairs. Muscle strength initially improves upon repetitive manual motor testing. Sensation is intact in all extremities. Which of the following mechanisms best explains this patient's weakness? Okay, so they're telling you that the repetitive manual motor testing improves, right? Muscle strength improves with repetitive manual motor testing. So when you get this kind of sentence in your question, you immediately want to think of between Lambert-Eaton and myasthenia gravis, right? Why is it myasthenia gracias? What the hell? Excuse me. So which one is which? How do you memorize that, right? And there's a bunch of other things you have to remember with them too. So this patient has Lambert-Eaton, which improves with movement as compared to myasthenia gravis, which worsens with movement. Lambert-Eaton usually has an association with small cell lung cancer, while myasthenia is related to thymoma. Now, how do you memorize that? So here the answer was just A, autoimmune downregulation of calcium channels. Okay, and here's the memorization stuff that I use to remember the two from each other and all the other relevant topics for it. So myasthenia gravis. Myasthenia gravis is more grave, right? More dangerous, more problematic. You do not have the receptors, and it worsens with use, right? You don't even have the receptors, autoantibodies to the postsynaptic acetylcholine receptors, which means that no matter how much acetylcholine you make, no matter how much acetylcholine you release, you're still not going to get any muscle use, okay? So this worsens with muscle use because when you start using muscle and you release acetylcholine, your acetylcholine ends up, binding to the few acetylcholine receptors you have, and then those acetylcholine receptors get tired, and that's it, right? Then you don't have any more activity. In Lambert-Eaton, something is eating your calcium, decreasing the acetylcholine release. Thus, giving more acetylcholine actually helps those patients, right? And how do you cause more acetylcholine? You can either give it to them, like actually medicate them with more acetylcholine, or you can make them use their muscle, right? Once they start actually using their muscle, they release more of their own acetylcholine and things start getting better. All right. The other thing is they also have a lot of autonomic symptoms like dry mouth and impotence. So that's another thing you really want to watch out for. It can be sneakily inserted into a question. Acetylcholine esterase inhibitor administration is something that's often tested. This will actually reverse symptoms, right? So you could use pyridostigmine for treatment. Basically, the part about acetylcholine esterase inhibitors is basically like saying you have antibodies that are killing the acetylcholine receptor. You don't want to also have acetylcholine esterase, your own enzyme, killing acetylcholine, right? You don't want to kill both things. So you stop killing your own acetylcholine so that at least some acetylcholine will, stick around, and whenever those receptors are available, the acetylcholine can work on it. Acetylcholine esterase inhibitors are completely useless in Lambert-Eaton because here the problem isn't that you're destroying your acetylcholine, you're not even releasing any of it. Like here in these people, their acetylcholine esterase isn't really doing much because there's no acetylcholine to destroy. Okay, so you need to give them acetylcholine to help them feel better. And as far as the cancer that's related, that's just something you have to memorize. Okay, so thymoma versus small cell lung cancer. So many URL questions here, so you can feel free to pause and check them out if you want to. The same page also talks about polymyositis and dermatomyositis, which are also pretty high yield. Also show up on NBME and will definitely be on your step 1. Okay, this one, 26-year-old woman comes to a physician 5 weeks after the birth of her first child. She worries constantly that the infant is ill and wakes him 10 to 14 times every night to make sure he is well, which is really weird. She has had no crying spells or problems with appetite. She is worried that she will infect the infant with her germs and washes her own hands 30 times per day. That right there is very much OCD. For 2 months prior to the delivery, she worried about people breaking into her house and checked the lock on the front door 3 to 4 times every night. She is not breastfeeding. Which of the following is the most appropriate pharmacotherapy? Since she's not breastfeeding, we don't need to worry about, that when we're picking a medication. And of all these medications for OCD, remember that in psychiatry, the easiest thing was majority of that shit was just treated with SSRIs, right? Or you give antipsychotics. She's not psychotic, she just has OCD, right? And a lot of these medications are antipsychotics, right? Or TCAs or something. But sertraline is just an SSRI. You just give it to her. Her ideas seem ego dystonic, where she knows that her obsessions are very unreal. This patient has OCD. OCPD is a personality, so their symptoms are egosyntonic, where they think they're perfectly right in what they're doing. Okay, most people you know are most likely OCPD. This patient is OCD because she knows what she's doing is kind of weird. Checking 30 times, checking the door 4 times, waking up the baby 14 times, all of that stuff, very unreal. And she knows, she just doesn't have it in her to stop. 5-year-old boy is brought to the physician because of a 4-day history of red cheeks and rash over his arms and legs. He also has a 1-week history of fever. He has received all of the scheduled childhood immunizations. His vital signs are within normal limits. Physical exam shows malar erythema and a red lacy rash over the upper and lower extremities. His hemoglobin concentration is 10, which is lower than normal, so he's anemic. Which of the following is the most likely cause of the patient's anemia? Okay, so now first you need to really figure out what's wrong with him. Right, it's a 5-year-old boy with red cheeks and rash. That should be a sign of slap cheek fever or parvovirus infection. There's really nothing else to think about. You would not think of scarlet fever or anything like that, because those are described as a sandpaper rash. It's not necessarily red. The only thing that would be, it wouldn't be red. They would have perioral cyanosis. It would be white around their mouth. Right? So that wasn't described here. This is not scarlet fever, nor is it going towards rheumatic fever or anything like that. And then the anemia is a giveaway too, because you kind of see that in parvovirus infection. So parvovirus infection infects erythroid precursors, causing interruption of erythrocyte production. This is the same way it causes hydras fetalis in unborn babies and aplastic anemia in sickle cell patients. So it was just C. None of the infections, scarlet fever, rheumatic fever, or parvovirus, none of them really cause antibody-mediated destruction of red blood cells or destruction of red blood cells in the peripheral circulation because of some infectious agent. Loss of red blood cells through occult GI bleeding, that never occurs from any kind of weird infection per se. Not at least not by an infection that's being described here. And sequestration of erythrocytes in the spleen is another thing that doesn't occur in this kind of scenario. Okay, they also told you he got all his childhood immunizations, so there's a bunch of things you can knock out there too. So it's pretty straightforward. You don't really get immunized against parvovirus. Right? Interruption of red blood cell production. 8-year-old boy is brought to the physician by his parents because they are concerned about his weight. His father has a BMI of 27, his mother has a BMI of 25, so they're okay. The patient is at the 75th percentile for height, above the 95th percentile for weight, and above the 95th percentile for BMI. Alright, before we continue, I do want to say that information like this one is almost always completely bullshit and irrelevant on NBME. So you don't even really need to read this. It's completely irrelevant. I've seen questions where the patient was at the 50th percentile for everything, and the answer was the person's perfectly normal. Unless the percentile is like, oh, they're at the 10th percentile or something, and they're very malnourished, that's significant, okay? But if if they give you basic percentages that aren't very alarming, you really don't need to worry about that. And even 50th percentile is good too, because the population is big and everyone's different, right? Physical exam shows no other abnormalities, which is a big plus, right? Everything's okay. Which of the following is the most likely explanation for the obesity in this patient, right? 8-year-old boy. Why is this 8-year-old boy obese? So you look at all your answer choices, you're thinking of an answer choice that actually causes obesity. And it's just A, calorie consumption that exceeds energy expenditure. You're eating more than you're burning. That's it. It would not be decreased leptin. It would not be diet with a high fat content or a diet with a high glycemic index. It would not be increased cortisol secretion or increased insulin production. All of these can make you gain weight. right? But they're not very likely. They're not very likely at all. This 8-year-old boy is just gaining weight because he's eating a lot and not going out to play. Other choices also make you fat, but this choice is the most likely. Modern day choices, right? A. That's it. They didn't give you any reason for you to think of leptin or high fat, right? Or high glycemic index foods. If they told you he had like acanthosis nigricans, then you could think of maybe diabetes, Increased cortisol secretion, you could think of also if they gave you something about pigmentation in him. Increased insulin production would also be with acanthosis nigricans, So D and F pretty much both very similar, but there was no reason to pick any of the other answer choices. Oh, yeah. Okay, so again, biostatistics, very high yield stuff. They love asking about this. A population of vegetarians is surveyed to investigate the association between garlic onion consumption and serum cholesterol concentration. The following results are found. So the results are just showing you how much garlic or onion you eat and how much their cholesterol is. People that eat a lot of garlic or onion have a lower cholesterol than the patients who eat low garlic or onion. That's all I'm learning from this chart, right? No. A positive nitrogen balance would be a patient who has high protein intake, right? This is high caloric intake. Most likely the kid is just eating something like a lot of ice cream or cookies. What do kids these days in America eat a lot of and then not burn off? So cookies, right? Junk food, chips, stuff like that, not really protein bars. High nitrogen balance is usually seen in patients who are taking in a lot of protein things, protein bars, protein milkshakes, protein in their coffee, right? Because they're trying to work out or something. And those people will have a high positive nitrogen balance, which is not so bad, right? And what are signs of a positive nitrogen balance? It kind of reflects in their urine. You can see it's going to be very foamy because they're urinating a lot of amino acids, and that's generally what's happening there. But their kidneys are working, their kidneys are taking care of it, and whatever excess amino acids they're taking in is just being urinated out. But having a high nitrogen balance or positive nitrogen balance is more or less okay. Having a low nitrogen balance is bad, right? A negative nitrogen balance is bad because that means that you're destroying your own amino acids to fix that, right? There's no other way to fix a low nitrogen balance. If the patient is not eating it, they have to destroy their own body proteins to make more. All right, so discerning what data was given here was pretty easy, right? That's all they told you. Which of the following tests should be used to determine whether the means are statistically different? Now, this topic with these answer choices is actually in this test twice. Block 4 has another question about the same kind of stuff, and in that one, the correct answer is chi-squared because they're going to give you categorical data. Right here, this is not categorical data. Remember, categorical data is percentages, right? Categorical data of two things, percentages, or non-discrete numerical data, right? Here you have discrete numerical data, 159, 208, right? These are means, right? They're giving you means. Chi-squared, the categorical data, is not with means. So since we're looking at means of two different things, people who have high or low garlic onion consumption, it's just going to be the t-test. T is meant for 2. Right? And T is meant for 2 because T is the mean of two things. That's it. Chi-square is for categorical data. Categorical data will not have means in it, but rather they'll give you, another question would be something like 2 groups of people with blood pressure, a group with high blood pressure, and a group with low blood pressure. That's it. Right? No numbers, no means. That's categorical data. Okay, and then that's where you would use the chi-square test. Rank correlation and sign test. I don't even know what the sign test is, to be honest. Right? And then rank correlation is a whole different thing that obviously isn't relevant to this either. But, I would advise that if you're preparing for NBME, you should look them up because these answer choices could be in the next NBME you take. I'm not saying they'll be the correct answer choice, but they'll still be there. So you want to be able to knock them out. It's possible they could be correct. NBME is very dynamic. There's no predicting what's going to be on your test. All right, 95. 60-year-old woman comes to the physician because of a 1-year history of episodes of involuntary rhythmic jerking of her right leg and foot. These episodes last approximately 3 minutes. Neurologic exam shows an increased right ankle jerk reflex. Babinski sign is present on the right. MRI of the brain shows a 2 centimeter round enhancing lesion with interhemispheric fissures in the region of the central sulcus. Which of the following is the most likely diagnosis? Okay, so this area of the central sulcus is actually a giveaway for what's most likely wrong with her. But as much as this area is a giveaway, the enhancing lesion is a confounder, right? It'll confuse people. So now you look at all your answer choices. Astrocytoma, a lymphoma, meningioma, metastatic carcinoma, or oligodendroglioma. Right, so 60-year-old woman has a brain tumor, and they tell you it's a 2 centimeter round enhancing lesion with interhemispheric fissure, right? Interhemispheric fissure. This description that they've given is actually very good for a meningioma, but it's not what you've probably heard of. So let's take a look at a meningioma, because they don't describe it like that in the book, but they do show you a picture that's pretty similar. So meningioma, common, typically benign, occurs in females, most often occurs near surfaces of the brain in the parasagittal region. Extraaxial, which is external to the brain parenchyma, and may have a dural tail. Often asymptomatic, may present with seizures or focal neurologic signs like a positive Babinski sign. Right? Arachnoid cell origin, spindle cells concentrically arranged in a whorled pattern. Meningioma is one of the things with the Samoma body in it. Right? Arachnoid and pia are neural crest cell derivatives, right? Whereas the dura is not. So when we look at meningioma, it looks like this, right? Obviously very nicely circular, retained in one place. You can see the tail thing they're talking about, and it's in the, you know your central sulcus and stuff is like right here somewhere, precentral gyrus, postcentral gyrus, stuff like that, and it's in the intersagittal, right, in between interhemispheric, in between the two hemispheres. That kind of locational description that they gave, interhemispheric, central sulcus, round, enhancing, right, is perfectly talking about a meningioma, right? None of these others are really the way the meningioma is, right? The only other thing is a glioblastoma multiforme, which is also interhemispheric, but it's deeper. It's not so up there. It's deeper in the deeper brain structures, in here, in this level, not up there, right? So that's why you wouldn't pick A, for example, right? And oligodendroglioma, that one is a whole different thing too, because if you want to look at oligodendroglioma, it occurs, in the frontal lobe mostly, right? So it's not going to be that either. And just that basic knowledge of the anatomy of where each one of these occurs is very significant. They gave you a bunch of images in the book. This one is from USOMA RX, but in general, when you're studying these brain tumors, you should look up more x-rays. Very important to know how it looks, because it's not going to look exactly the way it does here. Right? These images are doing a good job giving you a general understanding of where things are and how they look, but it can look very different on your test, right? And it can look very different in your patient. Okay, so you see how glioblastoma multiforme also can mimic a meningioma thing, but they're very different, right? This is so white, right? Very, very bright. This one is not so bright because they're made of different things, and it's also not in the same area, right? Not in the same area, and this is a little deeper, whereas this is very superficial. It's actually pressing down on the brain. It's very superficial. This is inside the brain, right? And oligodendroglioma, gross image, right? It kind of just looks like your brain blew up. Right? So very, very unique distinctions between all of them. So you really should not be confused when given a question verbally describing how a brain tumor looks. Right? Very important to remember how they look. They can also just describe the histology of these things, so you want to make sure you know the histo as well. And then use whatever you have to memorize it. As an extra bit of knowledge, remember that meningiomas are part of MEN1 as well. Okay, so always want to remember that. MEN1 has a lot of things associated to it, so you want to make sure you remember that. It's also on the cheat sheet, and I just posted the cheat sheet on the community page. I had taken it off. It had a little mistake to it, but I checked it now. So if you do want to download it, you can go ahead and check out the community page, which is right here. So that's on my YouTube channel. 96. A 6-year-old boy who recently emigrated from Russia is brought to the physician by his parents because of unstable gait and incoordination for 2 weeks. He has had frequent pale, bulky stools for 4 years and 2 episodes of bacterial pneumonia and chronic cough since the age of 1 year. He is below the 3rd percentile for height and weight. Increased rhonchi are heard over both lung fields. Neurologic exam shows ataxia, absence of DTRs, and loss of proprioception. That's really weird, right? Stool analysis shows an increased fat concentration. Which of the following vitamins is most likely deficient? Very easy question, right? As soon as they told you that he's got a lot of fat in his stool, that means he's losing fat-soluble vitamins. Which of the fat-soluble vitamins has neurologic symptoms? Vitamin E. Vitamin E often presents very similar to vitamin B12 deficiency. And they were kind of nice to you here. They didn't really put vitamin B12 as an answer choice. Right, and you have to remember, so fat-soluble vitamins A, D, E, K, both D and E could be decreased in this patient, but you have to know that vitamin E deficiency is associated with demyelination of the posterior columns and the spinocerebellar tract. Also, vitamin E can be given to Alzheimer's patients as it helps with free radicals. Vitamin E deficiency causes neurologic symptoms and hemolytic anemia, right? Because vitamin E is necessary for working with the free radicals. If you can't, then all those radicals go ahead and destroy your red blood cell. Okay, vitamin B12 causes subacute combined degeneration. That's different. That will have more issues. It also involves some spinal thalamic stuff. No, corticospinal tract. So that's going to be a whole different topic. That's going to also have, well, for one thing, vitamin B12 deficiency won't have anything to do with fat soluble, right? It's not fat soluble. So loss of fat is not going to be significant there. And then vitamin B12 is going to have the hypersegmented neutrophils, right? So they tell you here, they do the comparison for you, right? UWorld also had a question about this where vitamin E was the correct answer, but vitamin B12 was also in the answer choices, and they didn't mention fat-soluble vitamin loss. And then you have to remember all the other things deficiency can cause, right? So here, vitamin E deficiency is just demyelination of the posterior columns, decreased position and vibration sensation, as well as the spinocerebellar tract, which leads to ataxia because of the cerebellum. But with vitamin B12 deficiency, which is right before, right here, there you get, where do they talk about it? Subacute combined degeneration, right? So you lose your dorsal column, corticospinal tract, and spinocerebellar tract. And loss of the corticospinal tract is what differentiates B12 deficiency from vitamin E deficiency. Corticospinal tract is the active motor, the descending motor tract, which also gets demyelinated. So patients have difficulty with motor activity. Okay, so now here is a question about the kidney anatomy. 27-year-old man who is a construction worker is brought to the emergency department 30 minutes after he fell from a ladder approximately 14 feet onto a pile of boards from a demolished house. A long, sharp piece of wood penetrated his left side, immediately inferior to the middle of the body of his left 12th rib. A CT scan shows that the wood silver has grazed the inferior pole of the left kidney, and its tip is resting in the structure immediately anterior. All right, this structure is most likely which of the following. Right, it's such an annoying question. So what's immediately immediately anterior to the inferior pole of the left kidney? That's what they want to know. So I found this really cool color-coded image that's showing you what's in front of each of the kidneys. Okay, and here the correct answer was your splenic flexure, right? Because you can see your splenic flexure right here in front of the left kidney, right? Whereas the hepatic flexure, hepatic area stuff is in front of the right kidney. So, I mean, I don't know if you would really know this per se, but what's anterior to the left kidney, what can you knock out? Well, you can knock out, suprarenal gland because that's on top of the kidney. What's anterior to the lower pole of your left kidney? Well, your stomach is, in front of the left kidney. Your duodenum is on the right side, so you can definitely knock out duodenum. Your pancreas is also in front of the left kidney, so, this answer choice and this answer choice can have some confusion there, but the correct answer was the splenic flexure here, right? So why you would know this, how you would know this is beyond me, but NBME wanted to ask this, so now you know. Okay, This is actually pretty high yield too. So during a clinical study, 15 patients with renal allografts volunteered to undergo treatment with drug X. The drug is converted to a purine antagonist that interferes with the synthesis of nucleic acids and is toxic to dividing cells. Drug X is most likely which of the following. So all you want to know is which one of these is a purine antagonist, and that's just azathioprine, right? It's in the name. That's kind of why they put cyclosporin here. They wanted you to be confused, but we just looked at it, right? Cyclosporin was related to interleukin 2. Tacrolimus was also related to interleukin 2. Rapamycin is another name for sirolimus, which is also related to interleukin 2. And methylprednisolone is just a corticosteroid. So the only answer you could pick is A. Azathioprine becomes 6-mercaptopurine, and it causes purine synthesis inhibition. Purine antagonist. Okay, number 99. A 42-year-old woman is brought to the emergency department by her husband after having a generalized tonic-clonic seizure. She tells the physician that she smelled a foul odor for several seconds immediately before the seizure. Her husband did not perceive the odor. From which of the following regions of the brain did the seizure most likely arise? Okay, so she tells the physician she smelled something before the seizure, but the husband didn't smell it, which basically is telling you that she had this kind of sensation of smelling something because of the seizure. Where could the seizure occur for you to have a smell sensation? And they give you all this in the brainstem, so you could definitely knock out this because you don't really get seizures in the brainstem. Like you do, but it's it's not that high yield at all. So you knock out a frontal lobe, occipital lobe, parietal lobe, temporal lobe. The frontal lobe, right, is related to more so like, all these things right here, right? Controls, behaviors, acting correctly. To be entirely honest, the only way you would really know this is because you would just know this fact. Burning rubber smell hallucination occurs as an aura for temporal lobe epilepsy. Okay, you would just pick the temporal lobe. But in all entire honesty, like, all kinds of weird things can happen if you're having seizures in almost any part of these different brain areas. So there's no real physiology for me to tell you like how you would really figure out temporal lobe as an answer. Just remember that temporal lobe epilepsy, right, which is right here, your temporal lobe does have the taste and smell areas to it, right here. So if you did know that, that's how you would get this answer correctly. But it's a very discrete, very precise thing to know. I think it's enough for you to remember that the auditory part is here. Right, but you do need to know all of this. You do need to know everything that's in this image. So, yeah, the taste and smell areas are right here in the temporal lobe, which is why the temporal lobe is the answer. She was having a seizure here, and then she thought she smelled something, but she didn't. It was just because of the seizure, right? She could also think she's hearing something when she doesn't, but that's very rare. What else was there? So the smelling is the only one that's really here. The taste is a little higher up. Right, so you can argue it might be frontal, it might be temporal, but it's a weird topic. It's a pretty weird topic. I didn't know the answer to this question when I did it, so I didn't want to pick occipital because I usually associate that with vision. Right? I think we all do. So I was between frontal or parietal, and I just went with frontal. I didn't really know. I didn't think it was gonna be temporal at all. So the temporal lobe is the one with the smell. Okay. Smell as well as auditory. I know the auditory stuff is there because of Wernicke and Broca. Right, but taste, your gustatory sensation, that's over here, the purple area. Right. Okay, last question for this video, and then I'll ask you back in like an hour to continue on and do another 20 questions. This one, 35-year-old man is brought to the hospital after a diving accident. Evaluation shows complete transection of the spinal cord superior to the level of the sympathetic nervous outflow. Which of the following responses will most likely occur if he develops a systemic infection? Okay. So, anyone with infection, what happens to them? Right, you get fever. So you look at our answer choices: alteration of thermostatic set point, cutaneous vasoconstriction, diaphoresis with aspirin ingestion, generalized involuntary shivering, heat production by brown fat. I mean, I really don't see why you wouldn't pick A. It's just, alteration of thermostatic set point is basically a hypothalamic process mediated by prostaglandins and is independent of the sympathetic nervous system. right? And that's kind of what they're talking about. Evaluation shows complete transaction of the sympathetic outflow, right? If you don't have sympathetic outflow, which of the following responses will occur if you develop a systemic infection, right? So some of these are supposed to occur because of systemic infection. Generally speaking, though, anyone with infection has fever. Fever doesn't really require sympathetic nervous outflow. These other things do, right? Sweating, vasoconstriction, shivering, right? Heat production. These are all things that require sympathetic outflow, right? But the alteration of this, that's just one of the things that your hypothalamus is able to do. Tan hats. All right, so we'll stop here for now, and then we'll continue on. I'll be back in like an hour to do 20 more questions and call it a day. All right, thank you very much for joining. Keep studying, and I'll see you guys again very soon.